good session.
Okay, great. All right. Well, good afternoon, everyone, and thanks for joining this afternoon session. I'm Dave Beiser. I'm from the University of Chicago, and today I have the privilege of moderating this panel. It's entitled Emergency Medicine, Divining the Future of Anyone, Anything, Anytime Medicine. So in 2068, our specialty will be 100 years old, and between now and then, there are many societal, business, technological, workforce, and demographic kind of mega trends that promise to kind of give us, anxiety probably about the future, but also promise to dramatically reshape what we do for a living on a day-to-day basis. This is something that I think has become even more kind of salient in the last several months as we've started to think about being replaced by chatbots and things, but we're not really going to concentrate on technology, or we won't put technology kind of at the center of this discussion, but I think it's going to be difficult to kind of keep it away. So it might creep in here, but that's not going to be the focus of this, this talk. So what we've done is we've invited a few physician leaders who are really kind of leading the change in very innovative ways, changing kind of the practice of emergency medicine in their organizations. And we've got representatives from the payer side, from the hospital side, the provider side, and then we've got a technologist who's working kind of, really at the cutting edge of the spear, like to implement this in their emergency department, and implement kind of new practice models in their emergency department. Now, before we get started with the panel, I'd like to invite Dr. Ronnie Otero up to the front. So in addition to having kind of our panelists help us divine the future, we decided to crowdsource this. So we held what we're calling the first possibly annual EM Futurist Essay Contest. And so we put that out there, and we got about 15 very high quality responses to this call. And so Dr. Otero is going to kind of bring you through it and talk to you about the winners. And then he's going to read the essays to kind of help us kind of get our brain in the right space for this discussion. So, Dr. Otero.
All right. Good afternoon. Thank you all for joining us. So I will, you will have to indulge me because I will try to act out these very interesting essays as I perceive them to have been written. So we put this call out for these essays. We had 15 submissions. We had 5 judges that had the unenviable task of picking these essays based on creativity, etc. So we couldn't pick one, so we ended up having 2 winners. The 2 winners for our inaugural Futurist essay are Maximilian Hawkins from Henry Ford, PGY2, and Dr. Mary Mikey, I hope I pronounced that correctly, from Beth Israel Deaconess. So I will read their essays, and then the panel can take it away from there, and we'll go from there. So this is Max's essay. I hear a high-pitched wee-oo sound and quickly open my eyes. How long was I asleep for? I look at the 30 monitors in the room and see a patient on a stretcher on monitor 1. I press the trauma button on my desk and see HAL 9000 begin the primary survey. This new SCT scan, which automatically scans everything with minimal radiation, begins scanning. Give the people what they want, I guess. HAL gets a sample of blood that gives me all the lab values immediately. Subdural hematoma found with 5 millimeter midline shift. Proceed with algorithm. I click yes. The neurosurgeon on call automatically gets message to come in and speaks to Hal. I wonder if it's her talking or another Hal. And I look at the clock, it's 10:10. It's been a month since HAL was implemented and 1 year since we've installed the SCT. I remember the thrill of being an EM doctor, but now I'm just watching monitors, overseeing the process. Is this really what I signed up for? Then again, Adeno 66 came out 2 years ago, and it changed everything. It wasn't safe to work, so we had to find an alternative. And then that alternative happened to be cheaper for the hospital, even with the HAL rights movement. H&P finished. Shall I proceed? I look at the clock. It's 10:15. I read it over. I couldn't believe it even documents vaccination history, firstborn child, birth city, and how all impacted care today. I clicked sign, and after only reading the first 4 pages, since when does HMP become 20 pages? Doctor, can you see the patient in room 23? I was happy to finally do something. I put on my apron, I grab a glass of water, and I walk into room 23. May I take your order? So that's essay 1. This is essay 2 from Dr. Meinke. Sign out is done, and she will leave a wake of AI-assisted diagnoses, but clinician-powered medical management of already dispositioned patients. Throughout her career, there's been a shift away from hallways to home care beds, crowded hospital wings to peaceful palliative alternatives, an alliance with architects to change the hospital basement feng shui to a place where ergonomics of light and color aid in healing. She changes out of her scrubs, unburdened by the chase of notes, litigation, or RVU productivity. Instead, she is fueled by the timeless warmth of a patient's handhold prior to intubation that night. The resident's eyes ablaze with a victory upon completion of his first pen-sized, ultrasound-guided paracentesis and the on-shift newsflash that her mentee will take her place among a long lineage of female chairs in their department. Exiting through the waiting room, the electronic board shows 87 patients avoided an unnecessary visit by accessing the telemedicine triage system, which arranges non-emergent visits with family medicine in the morning. She thinks about the extracorporeal cannulation simulation she is leading tomorrow morning in the Middle East, and she hopes that the robotic arms function flawlessly with the click of her mouse. Her reflex is to order late-night takeout post-shift, and it's been muzzled by a culture of collegial on-shift sandwich pushers. She climbs into bed feeling grateful for the reinstallation of patient-centered care, time with trainees, and the cosmopolitan think tanks established for research and innovation in her field. And when she goes home, her family reunion tomorrow, she describes her job as an emergency physician. Not one person will follow with, and wait, what's your specialty? Because it's 2068, and emergency medicine has been the leading charge of change since she matched many years ago. And I'll leave it to the panel and Dr. Beiser to take it from here.
Great. Thank you, Ronnie, and thank you for everyone who entered the contest. It was very difficult to to choose favorites. So with that, I'd like to invite our panelists to first introduce themselves and kind of the perspective that they represent, and then give us about 5 minutes or so of a pitch. And this pitch can be either something that you're working on that you think has the potential to reshape what we do on a day-to-day basis in the next several years, or something that you've got your eye on that you're very interested in that you think might potentially really change things down the road. So why don't we start? I'm going to start with Emily Hayden, who, in a very kind of meta way, she does telemedicine, and she was unable to join us. So she is our panelist up here at the front. And so I'm going to start with Emily to have her tell us a little bit about what she's doing kind of in the innovative space.
Awesome. Thank you. Can everybody hear me? Can you just give a thumbs up? I'm looking out at the crowd. Awesome. All right. So thank you. I'm building empathy for patients with sciatica and herniated discs, so I couldn't fly to Austin, so I'm here in my kitchen, so thank you for letting me be meta and be telehealth here. Quick raise of hands. Who here has heard of the Stuart Kaufman's Adjacent Possible? Made more interesting and more mainstream from Stephen Johnson's Where Good Ideas Come From? No hands. It's a great book if you get a chance. All right, so the idea is that for innovation to happen, we need to have certain tools in place. What innovation really is just combining two different things that we already have to create something new. And so there's something now, for those who don't know me, I'm very much in the realm of trying to understand how we can transform our specialty using the tools of telehealth. And now that we have the tools of telehealth, and now that COVID has brought the tools of telehealth more to the forefront, we've been able to create new possibilities. And so I'm at Mass General Emergency Department, and our team there has created our virtual observation unit and our mobile response program. And so in 2068, if I was going to write my essay, I think that this is going to be an integral part of our emergency care. Briefly, what this is taking the tools that adjacent possible of using telehealth, as well as our EMS colleagues who are already going into the patient's homes, who can administer medications, who can take vital signs, and so on, and basically bringing those two together and allowing us as emergency medicine physicians to care for patients within their homes, whether it be as ED avoidance. So before a patient actually arrives to the ED, can we give them the same acute unscheduled care within their home? And when I'm saying care, it's not just having a video visit, like a lot of people think of telehealth as it's a video visit or not. We're looking at a video visit with a telepresenter that is the paramedic. So the paramedic can obtain healthcare derived or obtained vital signs. They can do EKGs that can be transmitted. They can do labs. They can do medications, IV medications, and so on, and guided exams. This is happening now. We started this with our virtual observation unit in January of 2022. Yeah, 2022, where we have patients from the ED, not just ED avoidance, but those that are in our ED or observation unit, go home for observation services in their home using this marriage of telehealth as well as the community paramedicine or the paramedics. And so for me, thinking towards that future, we're going to be doing more of this, that our reimbursement systems are going to be changing, value-based care, that we're trying to offload the capacity of the emergency department, hopefully provide care at a lower cost, and keep patients at home where they may never even have to step into our emergency department. And with the building up of the hospital at home infrastructures, that they could seamlessly become an inpatient if they need to be within their own home, and again, never come into our brick ED. So I see in the future that we are going to be stepping outside of our brick and mortar ED, and that it's going to be natural. Society is going to know that we do this. Our healthcare system leaders understand that we do this, and that we're not only defined by the box of the emergency department. Thank you.
Thank you, Emily. The themes of the adjacent possible being kind of the mechanism for innovation is doing that next step, but then projecting that out in the future. I think that's where many of us stumble, and I think it's helpful to hear your perspective. And maybe we will be stumbling kind of out of the brick and mortar walls of our ED. So with that, why don't we just go down the line? We've got Garth Walker.
Hey, everyone. So my name is Dr. Garth Walker. I'm from Chicago, Illinois. I think before I go into my perspective, it's best to just understand where I'm coming from. So my background's in public health as well as federal government. And now I work for Rush Health, leading their ACO, their Accountable Care Organization. So I joined leadership for our state public health department at the height of COVID. And then I transitioned to the White House Fellowship, where I worked for the Surgeon General. And that has framed a lot in terms of how I think about where healthcare is going. So I lead our value-based care strategy for our health system. And when I think of value-based care, I think of two things: controlling costs, and then also thinking about the value that's delivered to different populations. And then, most importantly, accountability. And when we think about what happened during COVID-19, it was very much a manifestation of a health system nationally that's focused a lot on downstream care, procedures, not necessarily a strong investment in upstream, primary care and preventative services. So when I read at CMS that says by 2030, Medicare and Medicaid will have pretty much focus on value-based care arrangements, I'm actively thinking about how the health system orients itself around there. And in my work, we partner very much closely with our emergency department to be able to think about how we're able to control quality and costs. And it's pretty much a focus on primary care providers and thinking about the cost drivers in our emergency department. So when we talk about 2068, I'm thinking about what are the certain contexts in where emergency physicians can support the accountability in taking care of large populations. So, for example, one of the contracts that we work with is ACO REACH, which is a payment model reform from CMMI that focuses on health equity. So within our population, we are actively looking at data that reflects the population, where they're residing from. How do we implement social determinants of health to be able to impact behavioral health, to be able to impact, as well as the traditional clinical interventions. And partnering with the emergency department is very important in the context of, A, just tracking what are the readmissions, what are the volume that's going towards our emergency department, but also what are the challenges that our populations are dealing with? Where are they residing from within our catchment area? And how are we innovating at that juncture to be able to impact? And is there a role for emergency physicians to be able to partner with care managers or community health workers to be able to go out into the community and be able to take care of a lot of those complex issues? So I see that as a huge step in terms of where emergency medicine is going, and being able to address that by allowing emergency physicians to have a role in that accountability to be able to share in the payment model that's reflected in that. And we can get more into that as we move forward, but I'll pass it to my friend Derek.
Garth, good to see you again. And you, Jesse, as well. My name is Derek Robinson. I'm an associate clinical professor of emergency medicine at UIC, University of Illinois, Chicago, and also serve as chief medical officer and vice president at Blue Cross and Blue Shield of Illinois. Our health plan is one of the largest in the country. We have about 9 million members in our state, and we manage about $20 billion in healthcare claims each year. And it was very stimulating to hear those essays regarding the future of emergency medicine going out to 2068. I don't have a 2068 vision at the moment. I'm trying to figure out how to get through the next 5 to 10 years. But as I began to think about the opportunity for today's panel, it took me back to some of the conversations we were having pre-pandemic in 2019, where we were looking at the acute unscheduled care payment model that was endorsed by PTAC and came out of some of the macro work, and had some conversations with Susan Nesda and other EM providers in the Chicago market to see how we might move something like that forward. Pandemic hit, and those conversations really haven't come back, at least in my environment. But when I think about the future of emergency medicine in the value-based care space, I think it is important for us to really think about how we may show up differently in those conversations. I will tell you that, first of all, when you think about it from a health insurance perspective, you have that classic vision of a company that's managing pooled risk amongst individuals that are paying insurance premiums, but you also have all the companies that are in your community that you rely upon for services. Some of them are buying an insured product, and some of them are paying for every claim that comes through for their employees. And then you also have government, and that's increasingly capitated, which means you're having more private insurance companies that are managing that particular risk. The conversations around emergency medicine often evolve around a couple of things. One, the consumer or patient or member behavior, so what are their particular constraints, their SDOH needs, what particular alignment they may have with regard to where they seek service at. And then also there are conversations around sort of the site of care, is it efficient from a cost perspective? And looking at facility charges and professional fees, the frequency of visits and the like. I think the telltale sign is that often when employers are having conversations with their insurance carrier and providers around performance, one of the markers is how is emergency care decreased, whether it's on the care management side for the health plan or the provider in terms of ED visits and the like. And so we're not really integrated from an emergency medicine perspective in those conversations around value-based care arrangements. And so as I think about the future, I think about the integration of integrated medical practices and emergency medicine and hospital providers around how you manage the health for a population with a value lens on it. How do you ensure that you have the right infrastructure in place to manage care coordination, appointments? A lot of times when we're seeing patients, we're critically thinking about not just quality, but safe discharge, right? How do you ensure that you're managing that risk when a patient's leaving? You know where they're going, you know they're gonna get follow-up care and the like. Often we work in a very fragmented environment where there's not a lot of certainty around who's gonna pick up the ball when you finish your portion of providing care for the patient. And often you're going to do whatever is necessary to get all the information you need at that time to make the best decision based on the information that's available to you versus the system that you're operating in, bringing all those elements together, because there's not only a focus on quality, but also the focus on cost and efficiency, and how do we deliver the expert care that we provide in a way that not only improves the outcomes for the member, but also looks at it from a financial toxicity perspective, because we know that there are cost implications for the patients that we serve as well. So whether that's being able to send a member home, a patient home for a hospital at home, or a variety of other sorts of mechanisms that will help buttress up that safe discharge perspective. I think figuring out how we're better integrated into those discussions and having the infrastructure that's necessary, I think is really important to the future of emergency medicine. And certainly look forward to Jesse's comments and having some more thoughts around it.
Hi, everyone. Jesse Pines. I'm an emergency physician and the chief of clinical innovation at U.S. Acute Care Solutions. I have the privilege of having what I call a non-specific title, which I am, my charge is to make good things happen. And the areas I'm focused on currently are what we've talked a lot about here, value-based care, what Emily talked about, telemedicine. And just to present a future, I think what we've got to do is really look at it from the patient's perspective and think about how can we develop a payment system that supports emergency physicians to actively participate in innovation and population health that will improve patient care and potentially reduce costs. So that's really what we're trying to do. And you think about what patients face today. There are several, I think, lesions of acute care. First is that patients often get sick and don't know where to go, right? And we as emergency physicians are uniquely qualified to tell patients where they need to be, where they need to go. Two, when they come to the emergency department, they often get an inconsistent product, right? So there's a lot of variation from emergency department to emergency department in terms of what we do, our approach, crowding, length of stay, dysfunction, all the issues that happen. Three, we discharge patients into the ether, right? We discharge patients assuming patients are going to get follow-up at some point, but we've got no guarantee of that. Four is, as emergency physicians, we are not paid currently to address social determinants of care. So when it comes to the patient with multiple visits, it's often let's let social work see that patient. I'm not going to necessarily get involved. And the fifth one is we are currently in our environment not aligned in some of our hospitals when it comes to crowding in the emergency department. And also that's not aligned with patients. We've seen a dramatic increase in crowding, particularly over the last 2 years. So what I think we're going to see in 2068, and hopefully well before that, is a system of global budgets for emergency physicians. And this is one area that I'm really working towards pushing, where we've got discussions going on in the state of Maryland that actually does have a model that could potentially test this. And the concept is if you can actually pay emergency physicians to be more like firefighters as the fire department, you think about, okay, so how does a fire department get paid? What the fire department gets paid to manage fire prevention and to manage the number of, when the fires happen, to put out the fires. But it wouldn't make sense to actually pay the fire department based on the number of fires in the community, right? You want to pay based on, are they able to prevent fires and make sure they have the resources. And I think a global budget does get us there and have some of the resources we would need. And essentially, it's not a lot. It's about having, having the system pay us to perform these population health functions that, if we do it, it will benefit the patient and will improve health and reduce total cost of care. One of the early projects I did, this was about 7 or 8 years ago, is I spent some time with a guy named Jeff Sullivan, so Jeff was the architect of the Kaiser acute care strategy back in the 90s in California. And the question at the time is, what can emergency medicine do with a fixed dollar to impact acute unscheduled care? And at the time, they implemented a lot of what we're talking about here. They implemented strategies to bring telehealth and digital care to the patient's home. They tried to make emergency medicine more standardized through protocols, making sure that people get follow-up after their visits, addressing social determinants of care, and making sure the alignment is there. So really, I think that global budgets is ultimately where we need to be. And I think as a specialty, what we really need to push is that emergency physicians, if given the right incentive, and I think a good mantra is form follows finance. If we have the right incentives to impact population health, we're going to have a dramatic impact. One of the studies I did actually with Dr. Sullivan, and I'm going to stop talking in a second, was we looked at Kaiser California versus non-Kaiser California in 2011. And the rate of ED use for the 65 and under population with all these systems in place was about 2/3. So 2/3 the number of ED visits. When it came to 65 and older, the visit rate was similar, but the inpatient utilization was about 2/3. So I think that's the kind of impact that emergency medicine can have if we implement the right model.
Excellent. Well, so lots to think about. I wanted to ask, do we have any health services researchers in the crowd that are willing to self-identify? Okay. Well, if you were a health service research, you would probably resonate with the idea that our specialty ends up often being kind of the adverse event or the endpoint of your study, right? This is what we were trying to avoid on most days of the week, is a visit to the emergency department. And we've heard a little bit about kind of how rising consumerism might kind of help us direct patients to the right level of care. But once they get there, then I think we need to ask ourselves kind of, what is our role in a value-based system? 2030 is only 7 years away, right? And so if you can imagine, I don't think we'll be there, but if you can imagine kind of the federal and state payers drastically shifting towards risk-based contracts by 2030, where does that leave us except an adverse event? So we need to be thinking about where we are in that conversation. And so will the answer be, well, we are going to address SDOH, we are going to address transitions in care and be a more active part of that solution? Are there other things that we might get involved in? Are we going to be managing chronic care? Are we have many patients that come to our emergency departments with multiple chronic diseases that are poorly managed, and we were often we were qualified to manage many of these, but we mostly choose not to. So I'm just going to throw that out there just to be a little bit controversial, because that's not why most of us got into emergency medicine, right, to manage chronic disease. But I wanted to kind of open that up to the panel, and also if panelists want to ask each other questions, and then we'll open it up to the audience. We actually are ahead of time here, so we're going to have plenty of time for audience questions. So if anybody wants to comment on that, or just let it sit, and if anybody has another question, we could take that.
Sure, So it's been an interesting vantage point to observe the role at ER, and I'm glad Derek and David and Jesse both brought up, where do we sit in the conversation, particularly because so much is dependent on having a relatively fixed budget that's able to assess how sick the population that you're caring for is, or not. So I think naturally, emergency medicine physicians have a critical role, but essentially, I would say the voice is not necessarily to the level where it should be in terms of their level of impact that they could have on a population. And I say that because we understand the role that primary care providers have in terms of, and they're getting and PCPs having more attention at the federal level than any time before that at least I'm able to observe in terms of taking care of an attributed population that they are in charge of. You have 300 patients, you're paid $10 per member per month per patient. You have to control the cost of that. And your cost could tank if they go to ER, and depending on the disease, you could lose money. So having healthy partnerships in terms of strategizing for that population is very effective in terms of being able to determine the value that us as emergency physicians have in terms of being able to help reduce those costs both ethically and in the right way. To just point, one of our biggest values is being able to assess whether somebody's sick, then also to be able to think about the confidence that we have in terms of our partners. I make admissions all the time if I'm not confident that a patient is unable to follow up in 2 days. And I think that it may be a month if they're able to leave my emergency department. And part of that is not necessarily being proximal to the decisions to understand what is available and being able to be part of the strategy to be able to control that cost. So I think it's figuring out ways to bring emergency physicians closer to the table in terms of care management and navigation strategies for specific populations, and being able to demonstrate the value in terms of how they are doing against trended lines in terms of what's either determined at the federal level, state level, and then with payers that have play a stake in terms of determining that as well.
Yeah, I'll just add
Garth, it's
one
Emily
brief
here.
comment.
Oh,
go
Garth, can I
ahead.
ask you a question with what you just said there? I totally agree with you with trying to get the emergency medicine more at some of these strategic decision or the tables, get our voices at the table, rather than asking like, well, how do we do that better? Like, what do you think is the biggest challenge for us or biggest barrier for us from your perspective? Because we can all make sort of assumptions from our different roles that we're in, but the role that you have, I'd be really curious to know what you think the biggest barrier is for us as a specialty to get to that table.
Sure. So I think the role that I have is, I mean, I naturally think about emergency physicians, so if we were to put it across the mean, it's probably higher than what the mean is. But what I would say basic organizing among emergency physicians and making sure that you're able to identify the different interest groups that are putting forth payment models. And that could be emergency physicians getting together and engaging Center of Medicare, Medicaid innovation more. And what does CMMI do? They put forth different payment models. They look at how they do. And the thought process is to understand what works and to be able to generalize it in the future for things that we understand really well. So you could be at the forefront of something that's potentially innovative and then make sure that the writers or the people that are most proximal to putting forth those issues are able to understand that. And same thing at the state level, because that's Medicaid. That's different from obviously Medicare is federal. And, but when you're talking about at the state level, it's different because now you're dealing with 50 different demographics and micro trends that may be very unique. So the role that emergency physicians could potentially play is totally different. And that organizing is at the level of ISEP or whatever state ER physician group that are able to articulate the value, because that's what essentially you're putting your money up for.
When I went to my first conference that mentioned the triple aim, it was something completely foreign to me, right? It's not something we see in emergency medicine. This was probably 2010, and everybody at the conference, they were family practice physicians, internists. There wasn't a single emergency physician there. I was one of the only ones. And this was a completely new language, this idea of value-based care. And so we weren't at the table at that point. I think Jesse can comment on kind of getting at that table. I'm sure he was probably there at the table. We just didn't know each other back then. But yeah. Go ahead.
And Jesse will probably attest that I think it's one thing to be at the table and it's one thing to cooperate and it's another thing to collaborate. And I think often when providers come to the table around advocacy for different models and things to test and payment, it ends up being more of a competition, right? Everybody's kind of out for protecting their own piece of the pie. And we're emergency medicine has an easy red target on it, so it can be kind of hard to wedge into those conversations. There is appropriate use of the emergency department, right? There are certain cases that need to come in through the ED and be handled in that way. And I think as we look at those models, from an integrated care perspective, they should contemplate, a certain use of emergency medicine within it. Cost is an entirely different factor, though, right? And we can just put cost on the side of the table, and we can all try to figure out how to describe what and define what cost is. But I think for cost for our specialty can vary quite a bit, and it's not just our professional fees, but also the facility fees and things that go along with them, which typically stand as a huge outlier relative to other sites and sources of care. And I think that becomes a big challenge for us to figure out how do we wrestle with that particular animal in the direction towards trying to create that value-based shared risk model where there's the true alignment and collaboration. I think that's one of the big challenges that we have.
Yeah. My thoughts are, I think we need to start with the clinical models that work for the patient, right? So right now, the systems are not designed in this country that work very well for patients, right? There's primary care appointments take 10 minutes. There's not a lot of prevention that goes on. People who are in the emergency department, some of them don't need to be there. Some people are sitting at home and they actually needed to come in, but maybe they were afraid to come in. So the question is, how do we take clinical models that we know are effective and then design payment systems around those models that make everyone align to in those models? And if that is us as emergency physicians taking on different roles, for example, doing more population health management, actually, creating protocols around social determinants of health and frequent use in the emergency department, whether that's working outside the four walls of the emergency department, if that clinical model works, and if we can get the powers that be, whether it's commercial payers, whether it's the federal government, to create a model that will allow us to do that's really our success. And one clinical model that is actually very effective is a model that we had for several years out in Las Vegas called the culinary. Is anyone familiar with the culinary? Yes, so Jen and Brittany. So this was a really fantastic model. This was a center that the culinary is basically a union that set up a freestanding facility staffed by emergency physicians where there was zero copay for the patient. They could come in, come out, and they would be seen. We had advanced practice providers, we had expert emergency physicians, we had a good mix of folks who were working there. And patients didn't wait, and there were no copays. And when a patient came in, and let's say they needed to figure out their hypertension management, the incentive for the physician was to, okay, let's figure this out with you. Maybe I'm gonna just say, look, this is not something I do. Let me call the primary care provider and let me actually fix it for this patient. So again, models like that where where there's not a lot of out-of-pocket costs. Where there's not a lot of friction between the patient and the clinician, where you've got the incentive to make sure that everyone's okay, and actually sort of changing the mindset of what we do in the emergency department is, do we actually just see patients when they cross the threshold between the waiting room and they land in our room, and then we're responsible for the 4 hours that they're there, and then we're not responsible for them anymore. I think that We've got to change that mindset, and I think a lot of these models could change that mindset, that we're responsible for the acute care needs of this population, and we can reach out before the ED, after the ED, and sort of think about the skills that we have are both seeing patients in the ED and what I like to call air traffic control, right? We are excellent at figuring out where people need to be and where people need to go after they're initially seen, right? And how do we incentivize those models? I think it's about changing the payment system, changing our mindset in terms of how we care for patients, and ultimately I think it's going to benefit. I think it's going to benefit everyone because the reality is that the system is incredibly broken now. So that if you try to fix a system that's broken, there's a lot to fix.
So correct me if I'm wrong, but I think you just gave us an example of a freestanding emergency department that kept costs down.
Yes.
Was that? Okay. It is duly noted. I'd like to now open that up for questions from the audience. Dr. Otero has a microphone. He can get to you. Please raise your hand if you have a question.
Yeah, if you could just say your name and institution, that would be great.
Sure. This is brief and really easy to solve and answer and fix. Mark Courtney from UT Southwestern. I just would be curious if the panel could comment on what would surprise you more in 2068, that A, we still have EMTALA, or B, we still don't have a single payer system?
Take that. So I think the chance that we get to a single payer system is not particularly high, because I think in order to get there, we need to fix campaign finance reform, which I don't think is ever going to happen. So I would take that off the table for now. In terms of EMTALA, again, I don't think that EMTALA is going to go anywhere either.
2068 is a ways out. I'm going to lean on I would be surprised if we still have EMTALA. Probably named something else by then. I did some EMTALA enforcement when I worked with CMS in a Region 5 office. So I've seen enough stuff behind that veil to have an honest view at kind of things that work well and things that happen that shouldn't happen. But comparing between the two of those, I would vote on the EMTALA one.
I would be surprised if we have a single payer system by 2068. I think putting folks in more Medicare-like arrangements is probably most likely, and I think it's people's comfort level towards feeling as if we're trending towards that trajectory. And I agree with the EMTALA comments. Any other questions?
Great, thank you. Any other questions out there? Please raise your hand.
Oh, I'm going to throw in two. I'm going to do the telehealth version of the panelists there. I'm Dr. Courtney. I'm going to say that I do think EMTALA is going to definitely be either not there anymore or changed, especially if we are really truly going to get outside of the bricks and mortar ED. There are things that are different than someone showing up through our sliding glass doors, whether by ambulance or walking through. And so there's different resources out there that if we are going to dispatch mobile integrated health or something else, there's going to be definitely a change in what EMTALA actually is for the practicing emergency medicine physician. I also agree with everybody else that I'm very skeptical that a single payer system will be in place by 2068, maybe 2072, but not 2068. So.
Thank you, Emily.
Hi, I'm Dream. Currently at the University of Colorado, transitioning to Mount Sinai in a couple of months. Thank you so much for this talk. I have a two-part question, or I guess just two separate questions. One, especially when it comes to proving our value of the care we provide, especially with respect to chronic disease management, social determinants of health. I mean, there's certain measures we use, like possible admission avoidance, are cost-effective, but a lot of the impact we're having is more long-term. So I would love your approach, especially from the payer perspective, on how we could strategize as both operations people and research people to prove that value, which I know is a big question. And then the other follow-up question is, thinking about like global payment models or just generally more value-based care models, like how to approach provision of care without inadvertently exacerbating disparities. I know the goal is, of course, to strengthen transitions of care, but also not to necessarily minimize the level of care provided, if that makes sense.
Okay, so I'm just going to restate the question just so Dr. Hayden is able to hear. So my understanding is it's a two-part question. The first question is, how do we as practitioners and researchers demonstrate the value of SDOH, kind of addressing SDOH within the emergency department? The second part of the question has to do with how do we address, I think, some of more the chronic diseases and other kind of care that we could potentially address in the emergency department without kind of subverting existing provider relationships with the patients. I think is that reasonably accurate?
And not exacerbating existing inequity as well.
Yeah, and also in keeping an equity lens on this, how do we do this without kind of creating kind of a two-tiered system, I think, of like emergency care-driven primary care versus traditional, which there's got to be a gap there, I would suspect. So how do we navigate those tricky waters?
I'll provide a short answer to both of those, or a sort of answer. I think that the inherent challenge around solidifying the longer-term value of an intervention or a care model is hard. It's just as hard as other non-care issues that we see in society that we would like a local government or an employer or someone to invest in, but it's not going to pay off for a year and a half or 2 years or 3 years. When you think about budget cycles and investments that are necessary in order to make those investments. I see it on the business side. It's challenging, even not considering emergency medicine, just thinking about interventions that you might want a team to do on behalf of a population of patients. That's not going to lead to lower cost in 2 months. They're going to lead to lower costs in 3 years and longer life expectancy and a whole bunch of other benefits. But locking that down from a financial model perspective and getting folks to buy into it is challenging, especially when some things pan out and others don't. And so that remains a challenging conversation. On the value-based care side, with attention to not exacerbating disparities, I think you have to build into that model not only attention to driving improvements in your target, but also identifying where disparities in care exist and providing some incentive for the closing of those disparities as well. If that's not part of that model and discussion, then you do run the hazard of potentially exacerbating disparities, because you might be able to move the needle in a positive direction, but you might leave a subpopulation behind in the process. And so if that's not part of the discussion on the outset, then that's something that can and will happen.
Great question. I think the first thing that jumps out at me is as we transitioned into Biden's tenure, one of the priorities was, frankly, just getting data on health equity, social determinants of health, clean, clear data that people can operate off of. And I think with some of the models that we just mentioned, and as what we're also doing as well with our health system, is doing SDOH screening across our inpatient side, primary care providers, and even in that, it can be very difficult to obtain. But the next step is not just getting the data, but closing gaps. And I think the notion of closing gaps is a complex question, because the interventions that you need to use are often not necessarily tied from your health system. They may be partners with nonprofits or state-led agencies that you need to be able to have a great relationship with as well. But I will say, having different health systems be part of models that are testing out financial benchmarks and rewards that are tied to closing healthcare disparities or reflecting the challenges of different populations. And I'm going to use the CMMI example again. Part of it is demonstrated by what proportion comes from an area deprivation index? And for my public health geeks, that's probably similar to like your social vulnerability index, kind of a zip code that may reflect the challenges that may make it more difficult for an area to remain healthy, and allowing that to reflect how much you're rewarded at the end of the day for managing that population. Things like that are informative to see if it plays a role in terms of closing healthcare disparities. But as you know, with every healthcare system, there's always unintended consequences, and part of that is just challenging your leadership to try to be aware of what it means to reorient resources within a health system. One of the, everybody has like a CHF ER reduction program or a COPD reduction program, but even when you look at those, you don't necessarily see a ER reduction across the global spread of that healthcare system. And you see persistent healthcare disparities among those populations. So being able to understand your data well and being able to put forth a global ER reduction program that reflects and looks at some of those intricacies will probably be the best way to be able to tie it to those benchmarks and try to be successful. But talented researchers like yourself asking those questions and being able to keep that top of mind for everybody everywhere that you're working at is one of the most important tests that I think we all have.
Okay, Jesse, do you have a comment?
Yeah, I don't have a whole lot to add. I mean, to that, I mean, I agree with everything that was said here. I think that narrowing disparities is all about figuring out what to measure, you know, having it clear what is being measured, because if, you know, what gets measured gets done, that's very clear. So coming up with the right measure, putting out the right incentives, and having the resources to be able to close the gap.
Great. So Emily's going to close with a comment, and then we'll go from there. Emily.
Do I get the last word? That's amazing. No, I was
The
just going
last
to say,
word.
I agree with everything that the panel has said so far, and I think the other piece that I heard from the question that was asked was about how do we try to make sure it's not two-tiered, where it's emergency medicine, primary care, and primary care. And I do think with the work we've been doing with our ED avoidance, with using our mobile integrated health and telehealth, we have come across or bumped into many times saying, should we be going to see this patient, because it's not truly avoiding an ED visit, it's actually avoiding maybe a PCP visit in 2 days. And should we go out and dispatch our resources? And should we be the ones managing things that are much more in the primary care world? And at the time, that's what the patient needs. And so we can go out there and do that. However, we have these like sort of existential questions for our specialty so many times, a couple of times a week, right? Like, is this the role that we should be playing outside of the brick walls of our ED? And so I think my thought on that one is that I do think we need to start having much more collaboration. And I know I heard that earlier when I asked about what's the biggest barrier to get to this, the voices at the table. And some of that's the cooperation and collaboration. So our collaboration with our primary care providers who are stretched thin, we're stretched thin too. We can commiserate on the burnout, and we can also start trying to be much more integrated with what we're doing. And I know that that's sort of lofty ideal, and I can't say exactly how that's going to happen. However, I do think that's important when we're starting to stretch our feet outside of the brick walls of our ED, because we are going to bump up against the different other specialty silos. And rather than bumping and trying to just shove our way in, is how do we collaborate and make sure that we're doing the best for the patients? So, which hopefully also will help with the disparities too. But the cooperation piece, I think, and collaboration piece, we're formed in silos of specialty. So the more we can start collaborating, I think is going to be helpful. So.
Thank you very much. That was wise counsel. I thank you, everyone, for your attendance. I know they're going to shoo us out of the room, but feel free to come on up and ask questions to our panelists as they attempt to escape. So, thank you very much.
I actually had lunch with Sharfstein recently.